those of you that don't know, Village Health is a division of DaVita, and it exists for one reason, and that is to demonstrate that integrated care management for renal populations results in better outcomes and lower costs. And I've been charged recently with trying to prepare our organization for a future where integrated care is more prevalent. And as Alan mentioned, the Accountable Care Organization component of the Health Care Reform Act may bring that future to reality. Being in this role is a little bit like being one of the characters in Waiting for Godot. There is a tremendous amount of noise about ACOs, a lot of talk, but we're all still waiting for a number of very important details to be resolved. One of the most important ones is, will CMS make it attractive enough for providers to be interested in making the types of investments that are actually required to make a difference in this patient population? Nonetheless, we certainly have taken steps over the years, and Fresenius has as well, the industry as a whole has, in preparing for this type of integrated care. And so what I want to spend some time on this morning is not focus on what's the structure of these organizations, how will the deals go down, et cetera, which I know is on a lot of your minds. But independent of all that, ACOs won't work if we can't make a difference in outcomes. And so that's really the underlying policy thrust. And so what I want to talk a little bit about is why we think it is a great opportunity, because we believe that you can make a significant difference in outcomes for this population, and that's all of us. So the first fact to be very cognizant of when you're thinking about ACOs in the renal space is that 10% of Medicare spend goes towards the care of patients with stage 4, stage 5, and ESRD. That is a very significant number. Anyone that is raising their hand and saying, I want to be accountable for a population of Medicare fee-for-service beneficiaries is going to have to figure out a solution for this 10%. It is too big a number to ignore. We've been in to talk to several hospitals. Not surprisingly, they don't know this. They aren't aware that fully 10% of what they're going to be accountable for if they go down the ACO path has to do with renal patients. So they will become aware of it over time, and therein lies a big opportunity for all of us. If you think about what can you do about that 10%, it helps to break it down a little bit. If you look at how the pie breaks down, thing that obviously jumps out at you right away is that the provision of dialysis itself, and this is for ESRD patients, is only about 31% of the total spend. The rest happens outside the dialysis center. And the biggest piece, of course, is hospitalization, which is 36% of the total. In the demonstration programs that we've operated, we've looked at claims data. We've had one of the benefits of doing those demonstrations. You get to look at claims data from Medicare for all services. It's how we can put together a pie chart like this. But you also get to look at all the diagnoses, and we broke down the hospitalizations, and it turns out that when you really look at the top causes of hospitalization in this population, fully 55% fall into what you could call our avoidable hospitalizations, and you know what these are. It's catheter-related infections, pneumonia, fluid overload, diabetes-related admissions, amputations. These are things which, with proactive investment in preventive care, case management, care management, you can make a difference in those, and as a result, we can make a difference in the total spend. What is it that you, as the primary accountable physicians for this population, can do? This isn't everything that you can do, but this is some of the things that we were able to achieve in the demonstration program, and the results are similar for Fresenius. One, we can improve the rate of early referral in our programs where we work with health plans around this population, we're able to drive the early referral percentage up over 95%. We've demonstrated that in our cohort, in our ESRD demonstration, we've been able to reduce catheters by 60% from the prevailing market norm, down to about 8 or 9% total catheters. In the cases of fluid overload, we've been able to implement more frequent dialysis, an extra treatment a week for certain patients that could benefit, work with hospitals to arrange for dialysis or ultrafiltration in the ER, et cetera. Preventive care, we've been able to drive immunization rates up over 95%. Medication management, there's data that the USRDS puts out that talks about the relationship between adherence in 4 key drug classes to overall cost and hospitalization. We, through a medication management program, were able to increase adherence by 25% in those drug classes. And then finally, end of life, obviously very important for this population and a place where a lot of dollars are spent, oftentimes futilely. What our responsibility really is to have the patients and the families understand what their options are, and we've increased the prevalence of advanced care planning in the population by 30%. So these are just some examples of what you can do and what we will need to think about doing in a systematic way in an ACO world. However the ACOs are structured, whether it's a renal ACO that we are sponsoring together, or whether it's a partnership with the hospital to help them manage the population that they're accountable for. Lastly, I'd like to say, how is it that you do this? Without sort of going, tick, tick, tick around every bubble here, it doesn't happen except through a collaboration between nephrologists and dialysis providers. And in fact, it doesn't happen without a pretty reasonable investment. We've introduced care managers, which is a new labor cost. We've introduced care management application that those case managers use. We've introduced the ability to exchange data between hospitals and our system. We've introduced remote monitoring capabilities so that we can track and interact with patients more frequently. Some of these other parts of the solution are things which I know you're familiar with. The industry has made investments over time which put us in a position to tie all this stuff together. Now it's up to us to actually make it happen. I think the takeaways are it doesn't happen by itself. It requires a focused program. And we certainly look forward to partnering with all of you in putting those types of programs together on a broader scale if ACOs take hold. Thank you.